Well, welcome everybody. That's our cue to get started. Thanks for joining our IDRPP Early Intervention Echo session. We're glad that you're here today. If you'll take a minute and put your name and contact information into the chat, that again just keeps us all knowing who is on the call. And if there's something that's shared, we have a way to, not just we, meaning everybody on the call has a way to get a hold of you. So like I'm at the IDRPP Project ECHO, so you can find my contact information there. If you've never been to an echo session, as you can see, we are recording that. We use those for educational and quality improvement. We also store those on our Canvas pages, our YouTube, and our website, so you can always go back and review the sessions, share the information, and by joining today's session, you are agreeing to be recorded in our videos. We do love participation. Today's session is going to be a little bit different, and we would love to hear your guys's conversations about some of the diagnoses that we are going to be talking about today. But always put your your questions, your comments, and everything into chat, and we will make sure those get asked and answered. We do talk about some sensitive topics, so please remember to protect individual privacy. If you have any questions about that, feel free to reach out to myself or any of our amazing hub team. They all have an asterisk or will now have an asterisk in front of their name so that they are easier to locate when you look at them for them in chat. Key components of an echo session is that we will always have a subject matter expert. We're really thrilled today to have one of our hub members and our director of services here at the IDRPP, Curt Phillips, sharing with us some information about degenerative diseases. And then case presentation and breakout groups where we discuss a case. Those are always the best part, in my opinion. I love hearing about what we talk about, but I also love hearing all the amazing comments and recommendations that everybody on this call has, because we all have such great knowledge and expertise. And that's where that professional networking comes in, is to just be able to know sometimes we're out here doing home visits and we're out here doing it alone. And so knowing who I can reach out to, or when Shelby Clark gives a great idea about speech, and I can then reach out to her and say, let me understand that a little bit more. I have a client that this is happening. I just have this great wealth of resources that I get to go and ask questions and do some follow-up. If you don't know how to rename your profile, here is a way to do that. And again, it's just so that we can know who's on the call and where we can reach out to everybody. I saw Janelle Boyer come on, and I always love when I see her name pop across mine because she spells it the same way as me, and she gets called out a lot on it because we're twinners. So thanks, Janelle, for always letting me call you out. In order to get a credit of attendance or a certificate of attendance, we do ask that you complete our survey. Our survey is what we take back to our funding agency to show all the amazing work that these echoes do and the reach that we have. So please and thank you to everybody who completes those surveys. There's also a question on the survey that asks for your contact, your mailing address, and phone number. The reason why we ask that is we love to just send you thank you gifts, so swag, and if we need to do some follow-up. So that's what that question is. Again, we store everything on a Canvas page. If you would like access to the Canvas page, that's where our recordings are stored, our PowerPoints, Also, all of the case recommendations that we gather through the different breakout sessions. So you may hear the case being presented and you're like, ooh, that is like a family that I work with. I want to see what other people have shared. You're always free to go back and review those case recommendations, download them, and keep them in your toolbox to use with other families. Just another plug for that case study. If you are interested in doing a case study, talking about it, hearing about it from all the amazing people on this call, please reach out to us at earlyecho@aggies.usu.edu, and we will get you on the schedule for that. We also have social media where we post things about upcoming sessions, information that is shared with us from different people, and then just other resources and tidbits that we find out. So if you want to take a minute and follow us on any of that social media, that is great. And then I am going to stop sharing this slide and get it to the other one where I get to introduce Curt Phillips. Like I said, he is our Director of Services, a PT by trade, and he will do some further introductions. Curt, say something so I can find you on my screen really quickly.
I'm sick. I can't do the presentation.
You're not sick.
All right. Did you find me, Janelle?
I did.
Perfect. Thank you, Janelle. I'm always grateful for Janelle. She does such a great job facilitating this network and introducing the purpose of ECHO. I want to make sure that we understand as we get started. I'll tell a little bit about myself, but just understanding that this really is a collaborative process. This is something that ECHO, when it was designed a couple of decades ago in New Mexico, it was all about collaboration and figuring out best ways to do things. So in the previous slides, it says there will be an expert presenter. I have been an early interventionist for a quarter of a century as of today. Today, 25 years ago, I walked in the building for the first time and came from a very different background. But I've recognized over the years how community knowledge and knowledge that we share is really what helps us to become better. So I hope that as we go through this presentation today, it'll be a little different than the others. We're going to have hopefully some more conversation and interaction as we go through this. So don't ever feel like I can't ask a question. You don't have to wait till the end. Just pipe up. I'm going to be asking questions of the people that are on this call. But it is a collaborative effort, and that's where we get to the best place we can as we work for the best good of these little kiddos that we serve. So with that said, just a little bit about myself. I grew up in California. I played sports in high school and college, went to physical therapy because I had a knee injury in my second year of college playing soccer. And I went into the physical therapist after having my knee in a cast for 8 weeks. My knee wouldn't bend all the way, it wouldn't straighten all the way. And I remember sitting on the bench there, and he says, "I want you to just relax." And I said, "Well, if I relax, what are you going to do?" He says, "Well, I've got to bend it a little bit or straighten it to see where you're at." And I said, "That's going to hurt, isn't it?" And he says, "Well, yeah, it usually is a little uncomfortable." And I remember my little 19-year-old mind going, I can cause pain to people and get paid to do it. This is my gig. I remember thinking that. And, it's really interesting because all through PT school and in my first several years, I thought I was going to be a sports medicine physical therapist. That was my goal. I wanted to work with athletes. I wanted to work with adults and try to get them to where they could be their best athlete or their best construction worker or whatever it is. But over about 3 years of working in that field, it wasn't exactly what I thought it would be. So in the summer of 1999, I applied for a job up here at Utah State University at what was then the Center for Persons with Disabilities. And I got the job, probably because they're desperate and didn't have any other applicants, but it got me to where I'm at today. I came here with the idea that I would work in pediatrics and early intervention for a year or two, find somebody up here in Logan, Utah that had an outpatient sports clinic and start working there. And 25 years later, I fell in love with kids, and I love working with them. I do more administrative work now than I do actually patient care, but up until about 5 years ago, I was a full-time physical therapist in early intervention Part C. And I've loved it. It's been a great career. I wouldn't trade it for anything. I wouldn't trade it for being a sports therapist for the best teams in the world, professionally or college. I love what I do. And because of that, I wanted to share with you some of my knowledge, but hope you will also share some of your knowledge with me as we go through this. So go ahead, Janelle, to the next slide. So the objectives for today, what I'm really hoping to accomplish today is to define a few. Oh, go back one slide. Sorry, you may not. Oh, you may not have the slide because I didn't send it to you. I just put this one in today. So the objectives of this are, one, to kind of define a few of the degenerative diseases. What are they? What are the typical aspects of those diseases? Some of the strategies maybe we've used and the ways that we've helped some of these kids. And then at the end, I want to have a little bit of a conversation for 5 or 10 minutes about how we might work with these kids a little differently than we might some other kids. Okay, now to the next one, Chanel. Thanks. So common components of the degenerative diseases, a lot of times kids that have degenerative and typically genetic or neuromuscular diseases, they'll begin life kind of in a positive direction. Sometimes these aren't recognized ahead of time when they're in utero, and they come out and parents notice within the first weeks or months, he's not eating well, or she's not holding her head up, or these other things that kind of show that the parents become worried. And that's usually when they'll go to the doctor and the doctor will say, okay, yeah, your kid's 6 months and they're not doing this. And for me, it's nice as a physical therapist because most of these things you're going to see are those motor things. Kids, I always tell people 0 to 2 months, they're just supposed to look cute. That's all they really need to do. We're starting to work on some head control. We're starting to do that. But by 4 months, we really should be holding our head up and doing some of these things. And parents start to notice that they're not doing what the other kids are doing. And so they kind of start sometimes in a positive direction or at least a neutral direction. And then over time, those skills that they either developed or I guess they developed, whether it's at a typical rate or not, you'll start seeing those either slowly disappear or sometimes they'll rapidly disappear, these skills that they've developed. And it's not just the motor skills. It can be cognitive, it can be speech, it can be any kind of skills that they've gained through their development. So mobility, I've had kids that have had some of these that we'll talk about today, these diseases, that were up and crawling and moving around, and all of a sudden they just stopped crawling, or they were sitting and now they're getting more floppy when they're sitting. We see discoordination where kids maybe before were doing some nice things with their fine motor and now they're not able to reach and grasp. And that could be a fine motor thing. It could be a vision thing. There's a lot of different reasons these things happen. Speech and communication, also cognitive learning behavior skills, and then vision and hearing. And we see with some of these that we'll talk about that will start off on that kind of upward ramp like we would expect. And then we plateau or we start dropping. And that's where us as early interventionists usually get called in, is when we start seeing that differentiation between what we would consider typical development and what parents are seeing, or if they start regressing. Okay, Janelle? So the other common, go one more, there you go.
Sorry.
No, you're fine. Some of the other things that happen is with degenerative diseases, because often they'll affect the brain, you'll start seeing new or increased incidence of seizures. And when I was a physical therapist before I was with kids, I always thought the seizures were really those myoclonic tonic seizures that where they're shaking and they're moving and that kind of stuff. And I've come to understand that seizures look a lot different in a lot of these, that sometimes there's just those seizures where they just kind of stare and blank out for a minute. And sometimes parents won't recognize that. So as early interventionists, we have that opportunity when we go into the homes to kind of help parents recognize some of these things. The regression in one area will often lead to regression in other areas as well. For example, if there's a decrease in mobility, that could lead to a decrease in social interaction. So maybe at home they're crawling, and then all of a sudden they stop crawling. They just sit there and their brothers or sisters or friends or play group or whatever go off and begin engaging in another activity, and they aren't able to engage socially. So that decreased mobility can affect not just their ability to get point A to point B, but also their ability to interact socially. That decreased coordination can lead to decreased mobility. If you're less coordinated, whether it's in walking or crawling or rolling, you might not be able to get to where you need to get to. Also, it may lead to lack of good feeding if the child's been eating from a bottle and all of a sudden they don't have the strength or coordination to hold that bottle at their mouth. And that can play into not just their frustration, but the family's frustration. Why is my son not holding his bottle anymore? Is he just getting lazy? What's going on? And those are some of the things that kind of pop up and either help the parents recognize, or if they've already recognized, help the parents be able to understand what they need to do moving forward. Decreased speech leading to decreased cognitive skills or school performance, obviously without the ability to communicate in a way that they've been used to. That can affect performance in school or cognitive. Also, the decrease in strength can lead to decreased ability with swallowing and eating. So you can see that it's not just one area, that anytime one area is affected, that multiple areas are affected. And that's why it's so critical with these degenerative diseases that we address not just, okay, my child used to be crawling and now is not crawling. Well, that's the key for us as early interventionists to go and say, okay, they're not crawling, but what else is being affected? Is it the social interaction? Is it their ability to get to and from things they want to for those adaptive and self-help skills? And we all know that anytime you have increased challenges, whether it's with a child with a disability or in general life, any of those can lead to family stress. And so as you have these kids who are doing great and moving right along, and all of a sudden they stop doing it or they start regressing, causes a lot of stress and a lot of anxiety with the parents. And that can lead not only to stress about the child's condition, but stress within the family. And that's may not be our expertise in dealing with family issues, but just a recognition that these decreases in abilities can lead to that increased stress. And then you'll see as we go through these three different disorders we'll talk about today, that they can lead to significant disability or premature death depending on the severity or the disease. So, all right, Janelle, I'm going to the next one. I do want to recognize that there are, I call them functionally degenerative diseases. I don't know if that's the right term for it, but this is kind of in a comparison stage. So the ones we're going to talk about today are actually degenerative processes that happen within the individual. For example, with one of them, we talk about that the nerves stop working as well with the muscles, and so the muscles don't work as well, and so this child actually loses skills. Some of these, for example, cerebral palsy is a static disease. It doesn't get worse, doesn't get better, but the ability of that child at a young age may be, he or she may be able to interact with peers on a fairly functional level, but as that cerebral palsy or spina bifida, spinal cord injury, begins to affect mobility or cognition or that, and it becomes more apparent, they fall behind functionally compared with their peers. So this isn't what we're talking about today, but I do want to recognize that there are things that happen, other disorders and diseases that happen that will functionally increase that difference between the kids that we're working with and their age-matched peers. So go ahead to the next one, Janelle. So we're going to start out talking about Prader-Willi, and I had a conversation with Pat right before. Prader-Willi, it's one of those potato. I don't know. If somebody knows this is absolutely what it is, let us know. I've always said Prader-Willi.
I was going to say next month, so November and December, we are actually going to have the Prader-Willi expert, so we can clarify whether it's Prader.
There's the teaser for next month's echo session. Come back to see if it's Curt that says Prader or Pat that says Prader-Willi, who's going to have to buy the other one lunch. So with Prader-Willi syndrome, sorry, Pat. It is a genetic disorder. It's caused by a deletion of the number 15 chromosome, and that's from the father's contribution to the child. It happens at or near the time of conception, and so this is something that does happen before they're born, and it's not something that occurs or happens once they're born. It's not generally inherited. I don't know that I've ever seen more than one kid with Prader-Willi in the same family. Inherited meaning the chances of having, if you have one, the chances of continuing to have more. But obviously, if the father's chromosome is dysfunctional, maybe is a word for it, that could be. The symptoms, and these are just some basic symptoms, and this is where I want people to kind of interact a little bit. If you've seen someone with Prader-Willi, as I go through these symptoms, please feel free when I get done with this slide, and I believe the next one, to chime in and say, this is what I've seen in it. But in the babies, you're going to see weakness, you're going to see poor feeding and slow development. As they get older, there's a constant hunger. This is one of the key things that I think the parents struggle with the most, is with Prader-Willi, there's a constant hunger, an insatiable hunger. I remember the first time I was exposed to this was probably 20 years ago, and there was a family, and when I went to see them, I picked this child up from another provider, and they literally had padlocks on their fridge and their cabinets because the child had learned how to get out around the child locks. And so they actually had padlocks on their cabinets where their food was in the fridge, because otherwise the child would just get in and just eat and eat and eat. There are intellectual impairments and behavioral problems as well. Um, and then I just want to share a couple of other things that I've kind of looked at. Prader-Willi, one of the main things you're going to see is that low tone. So I say weakness in here with the babies. It is a weakness, but there's that low tone. And anybody who's worked with kids knows that the low tone, they're just that floppy. You go to hold them, they kind of just fall into you and they don't hold their weight when you're carrying them. And that's one of the first things I ask when I go in and I'll evaluate a child if they have this diagnosis. I'll say, what does their tone feel like? What does it feel like when you hold them? If you've had other kids, do they snuggle up and hold on to you and keep track? And that's one of the ways that I look at and kind of evaluate what that tone is. Because like with anything, there's varying degrees of what we would call low tone or that floppiness. And so we need to get an idea of that. The feeding is often a big problem because you can imagine, especially with this kid that I was involved with 20 years ago, they had an older sister and everything had gone smooth. She breastfed, she developed just like she should. She ate table food when she should, and everything was going well. And then this child came along, and the first thing that mom notices, she just doesn't want to nurse. She just doesn't want to eat. And they tried a bottle and they tried all these different techniques to try to help this child eat better. And the doctor finally said, we need to get some testing and check and see what's going on. And they got the diagnosis of the Prader-Willi. So you can imagine how frustrating it is for the parents with that feeding. Obviously, with the low tone and the weakness, they're going to have some motor development delays. One of those first skills that we work on is that head control and putting them on their belly and trying to get them to look up and look around and developing from that head down, that trunk control from the neck to the shoulders to the abdomen, and then to get to the sitting and the crawling. And it all builds on each other. So if you can't get that head control, it's really difficult to be able to get that child to roll over or to sit or those kind of things. Also, the motor development with regard to the hands and the fingers and being able to fine tune those muscles as you try to come in and start picking things up and bringing things to your mouth. The strength in the arms and the hands can really play a role in it. If you go one more slide for me, Janelle, there are some other physical characteristics that you'll see with Prader-Willi. They'll typically have a narrow forehead, small hands and feet. They're typically short. And then the hyperphagia or obesity will lead to a large size, that they tend to be, like I said, obese and have a large size. The decreased muscle tone and poor sucking we've talked about. The poor vision, and I know there's a vision specialist because I saw Denise's name, and Denise, maybe you can chime in here. But the poor vision, some say it's due to the lack of coordination of the eyes. Are there other reasons you know, Denise? I'm going to put you on the spot here because we're good friends. Other reasons why they have poor eyesight, or is it mainly just because of the coordination of the eye muscles? Do you know?
You know, sorry, I'm not taking my camera off. I'm driving, or putting it on. I have had a couple referrals, and actually they didn't qualify for vision services, but I would imagine that might be why. I wish I knew a really profound answer, but
Yeah.
I
No,
don't.
sorry to put you on the spot. What I've read, though, is what you said, that poor coordination, because those small eye muscles, if those eyes can't converge, then their vision, they have a difficult time seeing depth perception and seeing different objects. So the other thing, excessive sleeping and a short attention span. Those tend to be some characteristics of the Prader-Willi syndrome. So what I want to ask is, has anybody that's on the call, have you worked with someone with Prader-Willi? Go to the next slide, and then I'll come back. Janelle, go 2 slides, and then I'll come back. Has anybody with, there you go. Has anybody worked with the Prader-Willi syndrome? And if they have, share with us maybe some insights you have. What were the highlights of working with the child? What were some of the challenges, the frustrations of the family? and the most effective interventions you tried so we can share this kind of information. And we'll get more of this obviously in the next couple of sessions in November and December with the Prader-Willi folks coming. But share with us if you've got anything. I'll give you a few minutes.
So Curt, somebody else is going. Go.
This is Janelle Boyer. It's interesting. I actually worked with a Prader-Willi young adult prior to being in early intervention. And so I had a different job that, anyway, I worked in a home that he was in. And they had to have those padlocks on the fridge, and his ability to regulate his emotions and stuff, that was impacted as well. So I don't have a whole lot because it's been a long time, but that was my experience.
I think Pat's got, go ahead, Pat.
Yeah, I've seen a lot of kiddos with it in various stages, and mostly in the newborn arena. And I've seen kiddos in the NICU, and we are all wondering what the heck is going on, and finally get a genetic test back. But the initial support so I think the horror stories that a lot of people have are that their child will eat an entire raw chicken and still want more. That hopefully with early diagnosis is going away because there's a lot of manipulation these days around their diet. They're getting ketogenic diet recommendations. They're getting injections to increase muscle bulk and tone. And so I just see them when they're lethargic and not eating. So my experience with so many families is they need to have hope with that child. And it's very difficult when they get on the internet and see all the horrible things that happen later on. But I think initially early treatment is what I understand is working, both early intervention and medical manipulation. And we're going to hear a lot about that, I'm hoping, next 2 sessions.
Thanks, Pat.
Yeah, and I was
just going to see if anyone else had some. Go, Janelle.
I was just going to say, Pat, that the point you made of giving parents hope, and Prader-Willi's has a great family connection throughout the nation. I worked with a few families that were really involved in that, and that's where they found out about some of those medical treatments. So like the growth hormones and food, diet kind of ideas. And so being able to connect families with those agencies or those resources so they are not feeling like they're out there alone. Because I think that that's one of the challenges that families do face, as well as because there are some language concerns that come along or behavior concerns. And a lot of times feeding or treats are one of the easiest things to work on for requesting. And so you can't do that. And what are some of those other activities? I remember one time back when we were at the CPD and I had a child that had Prader-Willi's, and we were trying to work on a matching toy game. And that was because she was so low toned, that was so hard for her to work on that matching. So we had to work on adapting some of those activities that to be allowing her to work.
Thank you, Janelle. And thanks, Pat and Janelle number 2. Anybody else want to contribute right here to this Prader-Willi? Because I can validate exactly what Janelle and Pat were talking about. As I think of the 5 or 6 kids that I've had over my career that have been diagnosed with Prader-Willi, the most difficult challenge was the guilt that the parents had. I mean, if you can imagine locking your fridge and your kid's like, I'm hungry. And you've got to do it because that's what's going to be in the best interest of the kid. But there's so much guilt, especially, when I go in and I'll work with the family and they're just like, it's so hard because they're always begging for food. Um, but, and I will say this is a way generalization, and I know I shouldn't make generalizations, but the kids that I've worked with Prader-Willi have all been very positive experiences. The child is less likely to scream when I come into the house than they would be when other kids might. They're always welcoming. They're snuggly. They love that sort of stuff. It's a feel good for me to be able to go serve a kiddo with Prader-Willi. So, um,
Do you see
so
the question?
yeah, I see the question in the chat. Thank you, Kathleen. So, and correct me if I'm wrong, for those that have worked, Pat, you've worked in the NICU with them. The diagnosis is typically done through genetic testing, and it typically is done, I don't know what the date line is, Pat. I mean, I've been in a family that the child had Prader-Willi and hadn't been diagnosed yet. And there was just all those symptoms. There was the low tone and all those kind of things that we've talked about as symptoms. And they got diagnosed probably, I would say, at 4 to 6 months in that area. What about you, Pat? What are you seeing in the NICU in that?
Well, the thing is that you see a 32 weeker and they're profoundly low tone. So, our preterm infants do have low tone, but these kids are profoundly low tone. They're like a little soup on the mattress. And so it is encouraging the neo or the nurse practitioner to get genetic testing done. And it shifts the trajectory of that child immediately. So you're not just dealing with a child with preterm issues, you're dealing with a child with a genetic issue. And it helps because they get plugged in to support systems. And as Janelle said, there's a huge support system. I've seen other children and the diagnosis was missed, even though it was tested. And that little girl ended up being incredibly high functioning because her parents did hyperbaric treatments. They did all this alternative treatments. They did all sorts of things. So I don't know why the kiddo, so she didn't get her diagnosis until she was 5, but she never showed that hyper phase, like whatever it is, wanting to eat a lot.
Mhm.
So I don't know if she was an outlier, but it's typically done in the newborn period, just like you said.
So go back 20 years. How much progress has been made there, Pat? And I'm putting you on the spot.
Night and day.
I was going to say, because the
Night.
one I'm thinking of that was 4 to 6 months was probably that one. That one that was about 20 years ago.
I know
And you
it's
just
night.
see that advancement in knowing symptoms and knowing what's going on so that they do get diagnosed in that neonatal stage rather than that 4 to 6 months to a year stage when things get bad enough the parents come to their doctor. So great
And the
question,
one the
Kathleen.
one child I tracked for quite a while, she immediately parents were she was breastfed, and then they really jumped into the ketogenic diet. And this kid, a treat was a piece of broccoli. And one time the mom gave her a little bit of banana and she thought she'd died and gone to heaven. So I think a lot of that behavior shaping around food is much more prevalent now than it ever
Yeah,
used to be.
absolutely. Thanks, Pat. Thanks for your contribution. Okay, we're going to roll back one slide, Janelle. There you go, right there. So this is just something I've put together. So as we look at early intervention, because I know we've got all different types of people here, we look at the concerns that you have with Prader-Willi and what can help. So as we look at that, especially as we get the diagnoses early, right out of the NICU or early on, motor people, the PTs and the OTs, the speech people, the feeding, the behavior. Dietitian, I think, is critical, and having a dietitian that's familiar with Prader-Willi and not just a dietitian that is an expert in this. And sometimes that means you probably have to go outside of that early intervention to get that expertise. The growth hormone therapy is another one. And then behavior services, I haven't really touched on behavior services because I haven't seen that in my experience, but I know that as they get older, as Janelle Preston was saying, we a lot of times will reward behaviors with, okay, if they'll walk to the end of the couch, cruise along the couch, just put some Cheerios along there so they can grab a Cheerio as they go. And that's not the best way to do it, especially in this situation. But trying to find ways to help with those behaviors as they develop later in life. So, okay, let's
I
fast
think
forward.
also, Curt, these are also some of those behavioral challenges that you do see in children, even toddlers with some of that Prader-Willi syndrome is that they do have that impulsive, obsessive compulsive behaviors. So a few of the kids that I've worked with in early intervention, they wanted to continue to talk about their favorite book time and time and time again, like, are we going? Are we doing this? Are we doing this? Are we doing this? And so that drives parents crazy. And how do you work on some of those behavior challenges with that? They might have emotional outbursts. Their moods tend to fluctuate. They do have difficulty with change. And then the skin picking is, I think, what parents start noticing a lot too, is because of that obsessiveness, they do start picking their skin, and what are the reasons for that? So I think thinking about some of those behavioral challenges, these are typically the ones that you do see in Prader-Willis.
Perfect. Thanks, Janelle. Janelle's an expert in this behavior modification. She's super good. So thanks for sharing that, Janelle. Go ahead and forward up to the spinal muscular atrophy. Go to the next one there. Okay, so SMA, or spinal muscular atrophy, until 5-7 years ago, was essentially, depending on what type you had, that you weren't going to get better from it. Within the last 5 to 7 years, they've had some genetic treatments that are helping these folks that are diagnosed with spinal muscular atrophy be able to maintain and improve their lives. But it is a genetic disease again. It's caused by a mutation of the gene, and the parents can be carriers of that gene. And so a lot of times, if you have a child with spinal muscular atrophy, they'll recommend genetic testing for the parents to make sure to see if they're carriers, and then that obviously, again, puts stress on that family of what are we going to do? We want a bigger family, but if we're both carriers, what's the likelihood of us having another child with spinal muscular atrophy? I'll talk a little bit more about these types, but there's 4 basic types of spinal muscular atrophy for the pediatric population. So 0, 1, 2, and 3. We'll talk about that in just a second. In the babies, you'll see the atypical reflexes. You'll see muscle weakness, that decreased tone, poor feeding. It's almost like a repeat of what Prader-Willi was. In the childhood, the decreased developmental rate. The W-sitting, which really is a compensatory strategy to give yourself a wider base of support so that you can sit a little bit more stable with less trunk strength. The weak cough and secretion. So the kids that I've seen, and I've seen a few of these with spinal muscular atrophy, they're small, they look frail, they look undernourished, and basically the neurons aren't connecting with the muscles like they should, and so the muscles never develop that strength. So you can see that, you can see the same type of things we saw with the Prader-Willi, that they're going to have difficult time sucking and swallowing and those sorts of things. I do want to just touch really quick before we get too far into the symptoms on these different types. So that type 0, as it says there, is a rare type. It's prenatal. Typically, children who are born with this type 0, or type 1A, they call it sometimes, they'll pass away within that first month of life. So it's a severe weakness, severe low muscle tone, and the respiratory failure is one of the reasons, because they just can't, those respiratory muscles just aren't strong enough to continue the breathing that they need to be able to survive. That type 1, or infantile, and I'm going to try to say this name right, but don't quote me on it. It's Werdnig-Hoffmann disease is another name that they call it. This happens, and it's kind of recognized within that first 6 months of life. So you can see on the slide here that about 50% of the cases of spinal muscular atrophy fall in this category. That within that first 6 months, it's diagnosed or it's recognized. That severe low tone, the hypotonia, the limited head control, these are kind of those indicators that parents start noticing and wondering and asking doctors about. Inability to sit up, in an appropriate amount of time, the 8-month or so area. Again, because of that severe hypotonia, because of the severe weakness in those respiratory muscles, a lot of these kids used to pass away within that first 2 years of life. And that the new treatments that are out there, I'm not as up to date as I should be on the new genetic treatments, but they are there. And I know I had a little kid maybe about 6 or 8 years ago that was in one of the trials for this new drug that they give the kids. And the parents were super excited because prior to starting that, I'd been working with the kid for about a year, and had gotten to a point where she was kind of plateauing, wasn't sitting, wasn't doing any of that kind of stuff. And then once they started the treatments, within about 6 months, I'd say, the child began starting to have an interest in crawling, pulling herself along the floor, and had an interest in sitting and those kind of things. And so there are treatments out there, and I'll look up and we'll put in the resources on the Canvas page, some information about that treatment for spinal muscular atrophy. But the prognosis is much better for those kiddos that have spinal muscular atrophy now. That type 2 says about 20% of the cases are there. This is usually recognized or diagnosed. The hypotonia, the low tone, isn't as severe. So sometimes parents just think, oh, they're a little lazy or they're a little slower, that kind of stuff. And so a lot of times it's not recognized till later along. So they a lot of times will get to the point where they've got the trunk strength to sit up. They've got the ability to, reach outside of their base of support and do some of this stuff, but their legs aren't strong enough. Their lower body isn't strong enough to walk. So they'll usually be in a wheelchair. They'll usually use a wheelchair for their mobility. A lot of times they'll live to be an adult, but again, that respiratory support and that a lot of times will require, oxygen or some other respiratory support because those muscles just aren't developed. They typically will use a wheelchair for mobility as they get older, but do, like I say, continue into adulthood a lot of times. And then this third one that's usually diagnosed after the 12 months, their life expectancy is pretty good. They'll live into adulthood, but they still sometimes will need to use a wheelchair or other assistive devices to be able to do what they need to do. One of the differences here that I want to point out between the Prader-Willi and the spinal muscular atrophy, because a lot of it is pretty similar as far as the symptoms go. And you can scroll to the next slide, Joe, is that there aren't the behavior problems. There isn't the cognitive delay that you're going to see with the Prader-Willi. So these are individuals who, while they may be limited physically by the spinal muscular atrophy, still can live a really functional life with the proper supports because of their not having cognitive delays, not having behavior delays that might shape what their social and academic or work life might look like. You see here a few of the characteristics of poor feeding. Again, when those muscles are really weak and you have that low tone, the poor feeding is there just because of the sucking and the swallowing. A lot of times because of the respiratory difficulty, they'll have a bell-shaped torso just because they don't have not only the muscles to maintain that typical shaped torso, but they use a lot of belly breathing, which expands those lower lung or the lower ribs to allow more space for the lungs than that to breathe. They do sometimes have atypical reflexes because of the neurological effect. The muscle weakness and tone we've talked about, the poor feeding, the weak cough with that lack of respiratory support, and then difficulty with breathing and secretions. So the kiddos that I've worked with, most of them have had some sort of a suction machine where mom would either have to suction if they had a trach, or if they didn't have a trach, would have to suction in the mouth because they weren't able to cough up the secretions and they'd kind of just hang out in the mouth. A lot of these kiddos will end up passing away because of a secondary consideration of respiratory disease, or they just get pneumonia and they don't recover from it. If you want to go ahead and continue to the next slide there. So as we look at the treatments, the medication and gene therapy, that's kind of what they're really turning to now. And again, early intervention in all the areas, the motor areas, physical and orthopedic, occupational therapy, respiratory treatments, feeding therapy, and then the dietitian and nutritional support to make sure they're getting the proper nutrients. Anybody in the group had a kid with spinal muscular atrophy that you know of? We know Pat has. Pat's had all of these. I'm going to have you chat in just a second, Pat, but I want to see if there's anybody else same questions, right? Highlights of working with a child, challenges, frustrations of the parents and family, if you've worked with them. So Elizabeth, would you like to share for a quick minute about some of these questions, the challenges or the highlights of working with a child?
I have not worked with them, but I have lived among a child that has that disease. I don't know if at this point I don't know much about it, but that's what I'm here to learn.
Perfect.
She was only not even 1 year old, and she already had done 5 surgeries with her. After the surgery, she could move her arms, her head, but not the legs.
Okay.
And then when they used to put her on, she was in a wheelchair. When they used to put her on the floor, they had to be very careful because she could not move from the bottom down. And if anything, like she needed to not all the time in the wheelchair or in the bed, so she put herself like she was like one of those worms, trying to push, and she could move this part, but it was so difficult sometimes because if she get a bruise, she would end in the hospital in an emergency room because she could not feel anything, but the bruise is there and she damaged some part of the skin, so she get like a humongous bruises.
Right.
So as she was growing up, then they moved to Houston, so I really don't know what happened to the child, but for some reason it was like this child was blessed in other ways.
Right.
So they were hoping that eventually she will walk like this baby here now.
Excellent.
But they move. They move away to another state, and maybe they return back to their country. They were not. She was an American citizen, but her parents were not.
Great. Thank you, Elizabeth. Thanks for sharing that.
You're welcome.
You can see Janelle's put up a slide here about how we as early interventionists can help the families. Number one, connecting them to resources. So once we find resources, making sure they're connected, making sure they know how to advocate for their child, and then whatever knowledge we have that we can help them make those informed decisions. So.
The worst part was as she's growing and her mother, it gets heavier and heavier, and she needed to carry it. There was sometimes she needed to carry this child, and then she was developing like a home here. So the parents, so most of the time they need a person that they can lift them up, because they can grow.
I think that's true with a lot of these, because as the kids get bigger, the parents have a difficulty. I've got a good friend whose son has cerebral palsy, and they still have to transfer him from his wheelchair into his bed, but he weighs about 140 pounds now, and mom and dad are getting older. So that is definitely a difficult thing. Pat, did you have something you want to chat in real quick, or someone else?
Curt, I had something that I wanted to just share based on something that you mentioned. And I think it's important for us as early interventionists to remember that and why it's important to know the diagnosis. So you had shared like that this particular diagnosis doesn't necessarily come along with some of those cognitive language delays and other behavioral concerns. And so understanding that what team members you might need to have for those teams, and what helping parents really giving them that information so that you can empower them to make more informed decisions throughout the intervention process.
And that's a great point, Janelle. It's one of those things that as we learn about what struggles the family that the child is having, to make sure we're connecting with resources, making sure, like you say, we've got the right people on the team. Pat?
Yeah, so I put in the chat a resource, and it's basically a really, heartwarming story about families who've had children pass with SMA, and then the research that was done by Dr. Butterfield, who is here in Utah. Yay. So he was part of this whole research project. So in the past, when I worked with these little kiddos, it was a death sentence. And it was just a matter of seeing what system was going to continue to shut down. But again, to Janelle's point, these kids are smart. They're typically developing in terms of their cognition. And so they know what it's like to feel breath hungry. I remember helping a mom transfer her son from the bedroom to the living room, and he was on a BiPAP machine, and she was pregnant, with her second kid with SMA. And I carried him in while she carried the machine, and the look of utter terror on his face, because he couldn't breathe. So these kids need to be treated as if they're typical cognitively. But again, it's not a death sentence if it can be identified in your utero and shortly after birth. There is this mRNA medication that the child receives, and the disease, it fixes their genetic abnormalities.
Excellent. Thank you, Pat. And you can hear from Pat. Pat and I have been around for a few years in this early intervention field. So we've seen, I mean, when I started in early intervention, if the child was 30 weeks or less, they automatically qualified because and now at 30 weeks, the kids have a pretty good opportunity of turning out pretty typically. So you hear Pat and I talk about 20 years ago, it was like this, and now we've got these great treatments. So thank goodness for those who are working in those medical research areas to help these kids have a chance to be able to continue in life. Let's go really quick. We're going to just take about a few minutes on Rett syndrome here. Rett syndrome is a little bit different than the SMA and the Prader-Willi in that kids with Rett syndrome typically will look pretty average. I mean, their development is pretty typical till somewhere around 6 months, 12 months, 18 months. And then all of a sudden they kind of almost fall off the cliff is the way I would say it. I remember having a kid like this maybe 5 or 6 years ago. And I went in and the mom's like going, yeah, she was crawling and she was starting to pull the stand. And then all of a sudden, you know, within just a matter of 6 months, she's sitting on the ground and we were working on sitting. There was no crawling. There's no mobility, not much strength in the legs, and just that terror, like Pat says, you know, the terror in the kid's face when he can't breathe. That was the same look I saw in this mom going, I don't know what to do. And she'd been diagnosed with Rett syndrome, but it's still that parent's going, what am I going to do? I mean, do I just sit here and wait for my child to not be able to do anything? And so it's really a frustration and unique in that way a little bit because for 18 months they look just like any other kid. And then all of a sudden they start that backslide. So you can see the etiology here. It's a genetic disease, almost always in the girls, diagnosed through genetic testing, not inherited. But, and this is maybe of interest to those of you who work with people with autism, prior to being identified as genetic origin, it was in the DSM, and it was linked kind of around those autism type disorders because not only does the physical start degenerating, but also the cognitive starts to slow down. Let's go to the next slide if you would, Janelle. So that stage 1 begins between that 6 and 18 months old. They start becoming less interested in toys and activities and things they used to love to do. They start paying attention to you less. They kind of are off. I don't want to say kind of spaced out, I guess is the word I would have used when I was a kid. But they start having these delays in motor milestones. And I think this is one of the reasons, and Janelle, you can correct me if I'm wrong because you're the autism, but that lack of eye contact was kind of what steered people to say, well, maybe it's kind of an autism type thing. And then that stage 2, which is where I came in with this kiddo 5 or 6 years ago, between that 1 and 4 years old, they start this rapid decrease. So in the matter of a few months, going from pulling to stand and getting ready to start cruising to barely being able to sit on the ground. Starts with speech and fine motor, and then the gross motor and other things come in. You want to scroll to the next slide and look at those last 2 stages. So the stage 3, sometime between that 2 and 10, it'll kind of plateau, and whatever skills they have at that level, they'll kind of continue at that level. They do have the apraxia, motor problems and seizures become more prominent, but they start kind of re-engaging a little bit more. And it's what I was reading is that this will often stay kind of at this stage for a longer period of time. Eventually, they'll reach that stage 4 where the functional ability will decrease. The muscle weakness and stiffness and increased tone come in, which decreases that ability to walk. So if they have in that plateau stage been able to maintain some sort of walking or mobility, a lot of times in this stage 4 as they age, they'll start losing that ability. So again, a very frustrating disease for parents. They have what they consider a typically developing child who all of a sudden starts decreasing in the abilities. Janelle, did you want to touch anything about the
Yeah, I was
autism type
just
stuff?
going to say, I think also, Kurt, one of the big things it is why it has been considered part of the autism spectrum back when it was the DSM-3 and 4 is really that because some of those things that happen in stage 1 and 2 do typically look like early indicators of autism. And if they stay in this stage 3, for a longer period of time where they're just that plateau, it really hasn't started hitting some of their muscle weaknesses or their decreased ability to walk. And so families aren't necessarily thinking about that. I know I've worked with a handful of kids that have ended up getting Rett syndrome. And it wasn't until they were like 4 or 5 that they were finally having that diagnosis, because that's when they hit that 4 or 5 years of age, when they hit that cliff that you were talking about. The biggest thing that was impacting them was they're less interested in toys, their communication, and their engagement issues.
Perfect. Thanks, Janelle. Elizabeth, you've got your hand up, and then we'll move to the last part of it.
Okay. Yes, I have. I've been knowing another child. He's autistic. He was recently, like a month ago. They did the assessment. That's what I'm going to take a trip to see them. They're in Florida. I don't know what is going to happen, because the child I knew, because I always talked to him, and he didn't have, as he was growing up. Now he got a head start, but as he was growing up, he couldn't talk. And then he made noises when he wanted to do something. He wanted something, and then but he could talk and do this and play. But as he was trying to communicate, it was very difficult for him to learn how to speak. So, I just wonder now that we're talking about this and the resources, because right now they deny help for her. They
Yeah,
said
the one thing mostly with Rett
what,
syndrome is that it's mostly in girls. And so there would be some resources to help that other child, and we can talk offline. And we'll just let
wonderful, great. Thank you.
Awesome.
Thank you.
Thanks, Elizabeth. Thank you,
Bye-bye.
Janelle. So let's just go to the last slide. Now, this is something I just wanted to have pose. I know we're short on time, but I just wanted to pose the question about what we would do as we look at, let's go one more slide there. As we look at these, and there's obviously a lot more diseases that are these progressive degenerative diseases. As early interventionists, the thing I want you to think about, maybe there's 1 or 2 comments that we could take on this, is that knowing that eventually we're going to see degeneration, how do we provide services for each of these type of diseases, right? Because if we know we've got a certain amount of time to get as far along the path as we can, is it a typical pattern? Is it a typical service that we would give if we had a child with Down syndrome that we know is not going to regress, or a child with cerebral palsy that we know is not going to regress? Do we provide services in that same way? Or I call it front loading. Do we really give those parents as much as they can handle right at first in the number of services and resources? And obviously, we don't want to overwhelm them. We don't want to put them in a situation where they are feeling like, if I don't do this, I'm a bad parent. But that's early support we give to everybody. But is there a different way that we might provide that support or those services to these kids, because we know we have that amount of time? And after that, we can't continue to build how high we are before we start coming down the ramp. So I don't know if anybody has any thoughts on that. If you do, maybe we take 1 or 2 minutes, Janelle. And if not, think about it in your own practice. Think about it in how you go about treating kids that have these degenerative diseases. Pat, you've got your hands up.
Yeah, I think we need to go back as to what our purpose is in the home. And are we there to provide therapy, or are we there to provide support? And if we go back to routines, what in your daily routine is impeded because you can't give your kid a bath, you can't get them to the playground, you can't, I mean, what in your routines? And if we can focus on the family as a whole and say, how can we facilitate this child within the context of the family. Range of motion exercises are not it. Sorry. I think we need to look at how we can support the whole family because they know they have a child with a degenerative disease who is going to become more and more dependent on them. So I think that's our solution. We already are doing it, I think, as early interventionists.
And you
I
bring
love
up
that
point.
point that you just reminded us, Pat, to really think about what is that family's goals for their family, for this child, and how do we help them do that better? And sometimes that is our role, right? Is to also just be there for support for those families. And why it's important for us as early interventionists to understand that child's diagnosis, to be able to provide the most appropriate resources for that family. I love
Right.
that.
And that's where I wanted to get with this slide. As an early interventionist, if I go in and provide a treatment for the child, and I'm doing it once a month or even twice a month, it's not going to make much difference for that child. But if I can go in and teach the parent and coach the parent and give resources and support that parent in what they're doing with their child, as well as the things like bathing or feeding or those other things that impact the family, that's where we're going to make our difference. And so looking at that and really being informed, as Janelle talked about earlier, making sure you know that diagnosis and know what the typical struggles are so that you're informed on that. So when the parent says, and I need help with this, you're ready to go and given those resources. I think it's critical that we really, this is my opinion, I'm just speaking as Curt right now, but I think we really need to focus heavily on that parent coaching and resources so we're ready when they come to us that we can provide that coaching. Because as Pat says, range of motion exercises are great and they're necessary, but if that's what we're doing as early interventionists, we're probably not fulfilling what our responsibilities are to that family, to really coach that family, as the slide said earlier, to know the resources, to support them in becoming advocates, and to continue to give those resources as time goes on. So that's all I've got for you. I hope it was worth your time. Thanks for taking time. Elizabeth says some parents leave them to the government to look after them. State of Maryland is a program where kids are assigned 24/7 in private house settings. They look after them the rest of their lives. Yeah, and that's, in my opinion, that's not a great way to go. If I had a kid with one of these diseases, I would want to be the one that's taking care of them as best I can, but I would need that help with the resources. So thank you to everyone who provides early intervention resources. And hopefully with these diseases, you can see how you can best support the
And
families.
I think, again, Curt, to your point of just what is our role is also not just to coach families, but to understand those diagnoses. Because how you talked at the very beginning, where a child that with this at maybe 6 months is going to look pretty typical. But if we know that, a child with Prader-Willi syndrome may be looking really good at one point in time, we do know that that's going to start to degenerate. And we want to make sure that we're not letting them out of services, or we're providing more appropriate services long term and helping the families also know how to advocate for their child.
Thank you guys for everyone who contributed. Thanks for being willing to contribute to this. I think we're ready for the case study now, Janelle.
So, Curt, we're not doing a case study. We're doing yours. So we are good. We will call it good today. And just a reminder that our sessions next November and December, so November 5th and December 3rd, we will be having our Prader-Willi's clinic from the University of Utah come and do a presentation where we're going to learn a ton more about Prader-Willi's and some of the supports for that. So thank you all for your time and your insights, and enjoy getting out a few minutes early. So thank you.